Good afternoon, dear colleagues. First of all, I would like to thank very much Mr. Apostolopoulos and the organizational committee for my presentation as a speaker during the 15th Pan-Hellenic Congress of Nuclear Medicine. Colon cancer is the second leading cause of cancer-related death in the United States. The most common sites of presentation are rectum and sigmoid colon. Mortality by colorectal cancer has reduced by approximately 50% by the adoption of new practices in the treatment and management of the disease. PET-CT with FTG is used in different, usually more advanced stages of the disease. Most colorectal cancers exhibit increased FTG uptake with the exception of mucinous adenocarcinoma, where uptake may be limited. In general, PET has no role in primary tumor detection or characterization, although some studies have assessed a potential added value. Knowledge of physiological FTG uptake in the large bowel and artifactual uptake secondary to drugs as metformin helps to avoid false positive results. Unexpected focal colorectal FTG uptake is seen in 2% of all patients with risk of malignancy or premalignancy and needs further investigation. Also, in 30% of patients with known colon cancer, FTG PET-CT revealed synchronous tumor. Nevertheless, we have to mention that only lesions more than 8 millimeters are detectable. PET-CT can't distinguish adenomas from carcinomas. All the cases are from Biomedical Research Foundation PET-CT department, where I was for 9 years. Here is a PET scan of patient with non-Hodgkin lymphoma at initial staging. There is a focal FTG uptake in the hepatic flexure. It was recommended further investigation with colonoscopy, and the biopsy revealed an adenocarcinoma. Studies indicate that routine FTG PET-CT is generally not beneficial in the initial staging of colorectal cancer, but it may have added value in patients with advanced stages of disease. Lymph node staging with PET-CT has false negative results mainly by very small-sized lymph nodes, as well as false positive results due to inflammatory or reactive processes. A big meta-analysis from 10 studies obtained sensitivity 43%, specificity 88%, and diagnostic accuracy 43% for characterization of lymph nodes in colorectal cancer, concluding that there is no evidence to recommend routine PET-CT for this objective. FTG PET-CT at the initial staging of colorectal cancer, according to the most recent guidelines, is indicated in the following cases: when it is of interest to exclude disease in other localizations in patients with potentially operable metastasis, for the evaluation of undetermined findings in TCT or MRI, and in patients in whom the administration of intravenous contrast is contraindicated. And especially in rectal cancers, according to the ESMO guidelines, FTG PET-CT has a role at initial staging for patients at high risk of metastasis at diagnosis as extremely elevated calcioembryonic antigen values or extensive extramural vascular invasion in the MRI. In patients with colorectal cancer and synchronous hepatic metastasis, candidates for surgical resection, FTG PET-CT can detect not identified extrahepatic disease, which excludes the possibility of surgical treatment. In a big meta-analysis in patients-based analysis, FTG PET show comparable results of sensitivity with MRI and better than CT for hepatic disease with very good specificity. In the lesion-based analysis, FDG PET-CT had lower sensitivity than MRI and comparable specificity, mainly due to the superiority of the latter in lesions less than 10 millimeters. The most important result is that FDG PET-CT presented an incidence of extrahepatic disease not detected by MRI or CT in 32% of patients and changed the management of 24% prevented unnecessary surgery. In conclusion, FDG PET-CT has a complementary role to MRI for hepatic disease, but a major role for detection of extrahepatic disease. In a similar study with a mixed sample of patients with surgical and for radiofrequency ablation candidates from Biomedical Research Foundation, we found that in 31% of patients, FDG PET-CT detected extrahepatic metastatic disease. With the results of most studies to confirm the above, the recent NCCN guidelines recommends FDG PET-CT in patients with colorectal cancer at initial staging with potentially surgically curable M1 disease. A case from the latter study. Patient with colon cancer and hepatic metastasis candidate for surgical resection, FDG PET-CT revealed a synchronous hepatic lesion as well as extrahepatic disease in the right abdominal wall, which excludes the possibility of surgical treatment. Another patient with colon cancer and hepatic metastasis candidate for RFA, FDG PET-CT revealed extrahepatic disease in a left common iliac lymph node, as also in a right mesenteric lymph node, and altered the management of the disease. Concerning the lung metastasis, FDG PET-CT has a very high specificity but low sensitivity compared with CT, especially for nodules less than 10 millimeters, so its main role is the detection of extrapulmonary disease. A patient with rectal cancer at its initial staging, FDG PET-CT revealed a metastasis in the left lower lobe. Regarding the role of FDG PET-CT in the evaluation of treatment response is less well established, but the majority of studies highlights that the therapeutic response via PET-CT is associated with longer progressive-free survival and overall survival. But it should be emphasized that our small studies and heterogeneous concerning number of patients, research questions, treatment regimen, scan techniques, and timing of scan. Studies have showed that FDG PET-CT in primary local advanced rectal cancer could evaluate the response to neoadjuvant therapy. According to the EORTC guidelines, FDG PET-CT contains the treatment strategy of advanced rectal cancer, fundamentally by early detection of non-responder patients. A meta-analysis revealed sensitivity 73% and specificity 77% for the differentiation of responders and non-responders to the neoadjuvant therapy. However, PET-CT is not able to detect residual microscopic disease, so it fails to accurately predict the pathological complete responders. FDG PET-CT is also useful for the evaluation of RFA of liver metastasis in patients with colorectal cancer. It is superior to CT for the detection of residual disease with sensitivity 86% versus 53 of CT, but the most important is that there is a change of management up to 54% of patients. FDG PET should be performed within 2 days following ablation therapy in order to minimize the risk of false positive outcomes of inflammatory process. A patient with colon cancer and liver metastasis, PET-CT scan after RFA revealed a focal increased uptake of the radiotracer consistent with residual disease. A low-grade intensity uptake in the periphery is due to reactive inflammatory changes. FDG PET-CT can differentiate viable from fibrous tissue in a presacral mass after therapy with very high sensitivity and negative predictive value and specificity a 96% positive predictive value 88%. In the first image, a patient 8 weeks after surgery for rectal cancer, FDG PET-CT reveals a symmetrical diffuse peripheral low-grade uptake in a presacral tissue due to inflammatory collection. Another patient in the second image with FDG PET-CT after chemoradiation for rectal cancer. There is low-grade diffuse tracer uptake in the presacral tissue due to post-treatment fibrosis, but there is focal uptake in a metastatic right internal iliac lymph node. There is low sensitivity and specificity of FDG PET-CT for the prediction of KRAS mutation in colorectal cancer patients, although FDG accumulation was shown to be higher in colorectal cancer with KRAS mutations. FDG PET-CT studies during the follow-up of patients with treated colorectal cancers with no suspicion of relapse, it is not recommended in the most guidelines. However, it is recommended in patients with repeated evaluation of CEA values in whom conventional imaging is equivocal or negative, and also in patients in whom curative surgery of metachronous metastatic disease is considered to confirm the absence of disease at other levels. In patients with evaluation of CA values in whom conventional imaging is equivocal or negative, a meta-analysis showed that FDG PET-CT has 90% sensitivity, 80% specificity, and a very high negative predictive value. In a more recent meta-analysis with 26 studies, sensitivity and specificity of FDG PET-CT were 94% and diagnostic accuracy 93%. FDG PET-CT is able to detect relapse even in patients with normal CEA values if there is clinical suspicion. In a retrospective study with half of patients with normal CEA values, FDG PET had 100% sensitivity and 84% specificity to detect relapse. Here is a patient with colon cancer with surgical treatment in the past and elevated values of CEA. FDG PET-CT scan revealed local recurrence. FDG PET-CT prevented worthless surgery for about 20% of patients with initially consideration for surgery of metachronous metastatic disease. The diagnostic accuracy of PET-CT for hepatic and lung disease is comparable with CT and MRI, but superior for other locations as abdominal lymph nodes, peritoneum, and bones. FDG PET-CT seems to be a useful molecular imaging method in evaluating treatment response of patients with colorectal liver metastasis treated with selective internal irradiation therapy. It may have a role in treatment planning and patient selection for SIRT, but more studies are needed to confirm this indication. Additionally, it is emerging as an important prognostic tool, especially referring to PET semi-quantitative analysis factors as metabolic tumor volume and total lesion glycolysis. According to the appropriate use criteria for FDG PET-CT in restaging and treatment response assessment of malignant disease, PET-CT is appropriate with moderate strength of evidence for detection of local recurrence or metastasis, as well as in the case of rising tumor markers with negative or equivocal first-line imaging. It may be appropriate for the assessment of efficacy of neoadjuvant therapy for advanced rectal carcinoma with moderate strength of evidence, in contrast with the assessment of response in other clinical scenarios where there is weak strength of evidence. In conclusion, in the initial staging of colorectal cancer, the main role of FDG PET-CT is in cases in which there is potentially operable synchronous metastatic disease. It is recommended if there is suspicion of recurrence by repeated elevation of CA values and conventional imaging studies are equivocal or negative, and in patients in whom surgery is considered for metachronous metastatic disease. FDG PET-CT post-chemoradiation therapy of rectal cancer can identify functional tumor response but fails to accurately predict the pathological complete responders. Although some studies have demonstrated the capacity of FDG PET-CT to change the therapeutic strategy by early detection of non-responder patients, its use remains to be clarified, and thus greater scientific evidence is necessary. Thank you very much for your attention.